There's a lot of, we don't want to go to the doctor because we don't trust you.
It's a fear that emanates from historical reality.
On many plantations, health care was attended to by veterinarians.
We have a responsibility to empower people, our people, and people in general.
What we're going to do today is create your account on the MNsure site and complete an application and submit it.
The reality is we're in this together.
Well, good morning, everybody. This is David Gillette talking to you from Twin Cities Public Television, and I want to welcome you to the third out of 4 chatbacks we're hosting here at TPT. This is a new initiative we recently launched. They're called Google Hangout Chatbacks, and they're an effort of Twin Cities Public Television to find new ways for our audiences to talk about the programming that we play on TPT. And our reason for doing this tonight is the topic of cancer, because tonight on Twin Cities Public Television, we're airing a program called Living Beyond Cancer, a celebration. It will debut at 10 p.m. right here on TPT2, and it's really triggered a larger conversation about cancer in our communities. And tonight, with a great panel we've put together, we're going to talk about racial disparities in cancer treatment, because it is an unfortunate reality in Minnesota. Like a lot of factors, education, income, healthcare, the color of your skin really has an impact on the quality of care and the outcomes you're going to receive. So if you are watching along at home today, we encourage you to chime in. You can reach us on Twitter at TPT, or you can just email us at tptmn@tpt.org. That email address again is tptmn@tpt.org. And of course, help answer any questions you might have. We have gathered a very prestigious panel today, and let's do some quick introductions, starting with the Minnesota's Health Commissioner, Ed Ellinger, who is featured on tonight's program. You'll see him right on TPT at 10 p.m. And he has also served as the keynote speaker at the Minnesota Medical Association's Health Disparities Forum in June. So welcome, Commissioner. Maybe you just want to say hi so everybody knows who you are.
Good morning. Hello. Good to see you.
Thanks for joining us today. Dr. Charles Rogers is also joining us right here at TPT. We're glad to have him. He's from the University of Minnesota's Program in Health Disparities Research, where he really focuses on colorectal cancer-related screenings and treatment disparities, particularly among African American males. Dr. Rogers, thanks very much for being here. You want to say hi?
Greetings, salutations. Thanks for having me.
Yeah, appreciate it. And then, of course, many in our audience will know Senator Jeff Hayden, along with his colleague, Senator Bobby Joe Champion. He's authored 3 major bills this legislative session in 2015 seeking to address this disparity in cancer among high-risk populations, including decreasing menthol cigarette usage, which we will talk about, and increased accessibility to colorectal screenings and expanding health care opportunities. And, Senator, do you want to say hi as well?
Good afternoon. How are you?
Good to see you today. And unfortunately, just a quick note, our last guest, Christine Rhodes, who's the Executive Director of American Indian Cancer Foundation, she's not feeling too well today, so is unfortunately unable to join us. But Senator Hayden, as we're waiting for some questions, let's just dive right in. Tell us a little bit about the legislation. I mean, we've spent a lot of time in Minnesota identifying these disparities, and I know you've been quoted many times saying it's time to move to action. Okay, what's the action? What's the legislation?
Well, this is kind of the start of what I think is starting to become the action phase. I know that Dr. Ellinger in the Department of Health has done a good job at identifying the issue and kind of retooling MDH to really address it. And so we think that these pieces of legislation, one, this issue around menthol cigarettes is really important. We know that African Americans, somewhere in the essence of 80% of African Americans smoke menthol cigarettes, and we know that the decrease in use that we've seen has not decreased in those that smoke menthol cigarettes. So we want to, working with Clearway and other advocates, we want to really start to put some resources to not only do outreach, but really talk to communities about how dangerous cigarettes are, but especially menthol cigarettes. The second one actually came from Dr. Rogers on our panel here. Him and I got a chance to travel internationally this year, and he really impressed upon me this issue of colorectal cancer, and that the issue that just being American Indian or Black increases your risk of getting it. So this tries to address the issue of bringing the screening age down to 45 and do a lot of work with Dr. Rogers and the folks that really understand it, Dr. Ellinger, and really try to appropriate dollars to get people screened early and to kind of get the outreach. And then the last one is really an idea that came from Babington Johnson from the Stair Step Foundation, who thinks that if we could develop pools of money small pools of money and grants at the local level, and have local small nonprofits, or could be larger, but really work at the local level, listen to them, and to see if we can work with NDH and others to appropriate money to start to deal with all of these issues around health disparities, especially these preventable ones like cancer, or to start the prevention conversation like cancer and early detection. That's kind of the package of bills that Senator Champion and I have put together to really start to move forward from a legislative perspective into action to decrease health disparities.
Well, let me ask you, Dr. Rogers, really quickly. I mean, when a lot of us go to the doctor, it seems like a pretty regimented thing. I mean, they have these checklists and these processes. And explain a little bit more, how do these disparities creep in? I mean, it seems like sort of an almost automated system. Why does the color of your skin have such an impact on this?
Well, it's definitely a complex situation, David. I've been studying this disparity for quite some time. And so, as Senator Hayden mentioned, the recommendation for the screening age for African Americans was actually lowered to 45 in 2008. So a group of gastroenterologists who do these types of work every day, they saw that the incidence and mortality rates were increasing. So when I initially started doing this work, African Americans had a 20% higher chance of getting it than their white counterparts, and a 45% higher chance of dying from it. So now, if you look at the most recent in this past year, those rates have actually increased. So now they have a 25% higher chance and a 50% higher chance of dying from it. So, you know, if we focus that on Native Americans, those disparities are even worse in the Twin Cities. So even though the Twin Cities typically ranks in the top 10 of one of the most healthiest states, it has some of the most serious disparities that are out there. So again, to come back to your question, again, it's very complex. It's not just recommending individuals get screened or not. It could be issues with poor patient-provider communication, mistrust in the provider or the system. It could be lack of insurance. It could be things in terms of guys, in terms of their masculinity, in terms of them feeling like it's tough and it's something they don't really want to do. It could be a lack of knowledge. It could be a number of things, just some of the things that I focus on in my research.
Well, let me turn that back to Senator Hayden, because I know your time is limited, Senator. That sounds like a lot of complex sociology issues almost. Is this something government can really tackle, or is legislation just one piece of a larger push on this?
Oh, I just think we're partners. This is the idea that we're, as a community leader and as an elected official, I think that people will often look at us to lead. And so I want to be kind of the Pied Piper of this issue and then put some resources to back it up. But it really is going to be a larger public health issue. You have, the state's top doc and one of the foremost public health doctors in the country, people like Dr. Charles Rogers. The mere fact that Dr. Rogers is an African-American man and a PhD researcher, those voices are going to be significant. What government can do, or what I can do as a leader, is really to help with the resources and help to kind of bring attention to it, so that these wonderful and accomplished men can really kind of dive into the issues.
Sure. Well, Commissioner Ellinger, I know you spend a lot of time on studying what actually works from a public campaign perspective. We all drive around town and we see these billboards saying, get yourself checked. I mean, what really persuades people to change their thinking about these sort of health screenings?
David, thank you. And I want to first comment on what Senator Hayden started out with. He started talking about menthol cigarettes. I think that cancer. My goal is really to prevent cancer in the first place, so that we can reduce the incidence and reduce the mortality. And one, it is by changing some behaviors. And certainly, we want to get people in to get screened for colon or breast or cervical cancer, all of those kinds of things. But we also want to really decrease the risk. So really focusing on tobacco use, as Senator Hayden mentioned, particularly menthol, which has been targeted to African Americans, and that public can do something about. We can set up policies, which we've done with tobacco overall, and which we can do. We're also working with FDA to try to reduce the menthol marketing as really one of the first steps. And then just generally have people think about, like our ads about colon cancer screening. Get people to raise their awareness, but particularly raise the awareness among people of color and American Indians, because they really do have a higher incidence and mortality for most of these diseases.
Well, how about the age aspect of that education? I mean, do you want to focus your efforts on youth in schools, like the drug awareness programs we all grew up with? Is it billboards for older Minnesotans? I mean, where do you focus your energies if you really want to change social behavior?
Well, I work with policymakers, first of all. I think that's where it all starts. I think a lot of the disparities that we have are because of policies that we have in place. And some of the policies that we have are about the price of tobacco. When we increase the price of tobacco, use goes down, particularly among the young, particularly among low income, and particularly among people of color and American Indians. So first start with that. Secondly, some of the other policies related to obesity. Obesity is also one of those things that leads to increased incidence of cancer. So we need to look at where we have food deserts, where we have an overabundance of unhealthy foods, and look at some of the policies that are in place in our neighborhoods to make sure that people have access to food. That's where we start. We start with policymakers because that has the biggest impact. And then I think certainly we start with the education. The younger the education starts, the better it is for changing behaviors.
So, Senator, as you know, Senator Hayden, it is difficult to change behaviors. What's sort of your time horizon on this work? Are you hoping 10, 15 years from now we'll see different statistics? Do you consider it more urgent than that, and you're hoping in just a few? I mean, when you really put these policies together, what time horizon are you thinking that they will take effect in?
Well, I think my job is to really kind of work as urgently as possible. We're in the halfway through the legislative session, and really impress upon my colleagues that this is a very important issue and try to get those resources and that campaign on its way. I think that Dr. Rogers and Dr. Ellinger and others can really understand, like, as these resources go and as we develop our campaign, what kind of is the likely timeline for people's behavior to change. I think they'll probably understand that a lot better. It's their work. I think my job, as Dr. Ellinger said, is really to kind of create the policy framework, create the resources, and get them to the appropriate folks to really push aggressively. For me, I think time is of the essence. Not to plug my own weight loss, but I think many of you probably have watched over the last year. I've dropped some significant weight, really thinking about that issue as I grow older. So I know that if people really put their mind to it and think about what they want to do, that their behaviors can change. And I'm trying to lead in that way as well. So I do think that a sense of urgency, and we can push that forward. But I think that the two doctors here kind of have a better sense of how that happens and how does people's behavior changes over time.
Sure. Well, let me ask you that, Dr. Rogers. Here's the big magic wand question. Unlimited money, unlimited political will. What's the first thing you want to do to really tackle this?
Yeah, so the first thing I want to do is definitely lower the screening age for African Americans and Native Americans in the state of Minnesota. So Minnesota is very, very good, has a great history of actually modeling the way in terms of addressing any issue, whether it be same-sex marriages or public health issues. And so I think this is really another way that we can lead the way in terms of making some changes that can affect the entire state of the United States, or the United States rather. I definitely agree with everything that Senator and Commissioner both said. As a certified education specialist and behavioral scientist, I look at prevention all the time. And so the things that Senator is starting to bring out to the forefront in terms of smoking and obesity, like Commissioner mentioned, those things are definitely risk factors for colorectal cancer and other chronic diseases. So I'm on board, but that's definitely the first thing I would do if I had unlimited funds and access to changing policy.
Well, you mentioned changing the age to younger. Let's just go over the basics now. If someone listening is hearing your message and saying, okay, when should people get screened? What age? How often? What are the real basics here?
Yeah, so the gold standard that's been put forward by the United States Preventive Task Force is age 50 for everyone. At average risk, if you have a family history of it, you should actually get screened at age 40. And so those things, typically you hear about the colonoscopy, which is every 10 years. But you actually can get a FOB test or a FIT test, which is actually a stool test. The only thing with that test, you may have to get it more than once or basically every year to make sure that you're good to go. But a lot of people don't know about that. And so some of my work in the future is really looking at that and see if that actually can address the barrier of people not getting screened.
And then just one more question before I switch over to the Commissioner. How treatable are most colon cancers? I mean, let's say, God forbid, you get a result you don't like. That's very scary stuff. I mean, early detection does lead to decent odds nowadays. Is that true?
Absolutely. So unlike other cancer, colon cancer is actually very treatable and preventable. If you catch it early, you have a roughly an 80+% of surviving, versus if it's like in stage 4, you have a less than 8% chance of surviving. So it's really good to get that get it checked, get screened as much as possible. And since it's Colorectal Cancer Awareness Month, that's all I've been doing in regards to participating in events like this to really spread the word, get the awareness out there.
Find out early, absolutely. So, Commissioner, I want to ask you, you have to deal with a lot of public health issues. How high does this rise on the overall radar? I mean, is this a real significant issue for Minnesota? Is this a point of education? I mean, how much energy do we really have to direct at this specific issue?
Certainly, cancer is in Minnesota the leading cause of death, so it's a huge issue.
Leading cause, even above heart disease?
Yes, because we've done a really good job with reducing smoking and good care for people with heart disease, and control of blood pressure. We've done a good job so that we're one of the 2 states where cancer is the #1 leading cause of death. Also, the longer we live, the more likely we are to have cancer. So our increasing life expectancy increases the risk of cancer. So cancer is really an important issue. But the disparities are there, and I think to deal with the disparities, we can't just focus on cancer disparities. We have to focus on disparities in all health issues, and because the things that we have to do to reduce all disparities will certainly impact cancer. So I'm focusing on how do we reduce disparities. That's why we put out the Advancing Health Equity Report. We really want everybody to have an equal opportunity for health, and that requires a whole variety of factors that will impact disparities in infant mortality, disparities in cancer, disparities in heart disease, disparities in dementia, disparities in all sorts of issues.
Sure. Well, Senator Hayden, let me ask you about one of your earlier comments that it's time to move beyond identifying the problem and really focus on solutions. When I listen to the Commissioner and Dr. Rogers, it sounds so complex. Is there a chance? I mean, there's a lot of political will to overcome disparities. We all know that. Is there a chance we haven't completely identified the problem? Maybe it's a little more complicated than we still realize?
Well, I do think that it is complicated. I do think that the Advancing Health Equities Report helped really it's a document that all of the legislators have access to and really can look at the research that the Minnesota Department of Health has done. I think the kind of work that Dr. Rogers is doing that is, research-based and data-driven and not a lot less anecdotal is helping. And I think that my colleagues are really starting to focus in on this issue, especially in our health committees, which, I'm pretty proud of. They're really understanding this issue in all facets of it. So I am really hopeful. I know that we have health disparity fatigue on the committee. Well, what I mean by that is we hear about it each and every year, and people are getting to the point where they're tired of hearing about it. And so my job is to get us to do something. So, it becomes a political issue. Our political targets are out. We all have a certain amount of money that we have to spend. Each body has their own targets, and so I'll be fighting hard to get these resources in the overall omnibus healthcare bill, and then try to hold on to it and hope that our chairs and our colleagues in the House recognize how important this is to people's health, but also how much it costs the state. I know Dr. Ellinger and others, I can't speak on behalf of the administration, but Dr. Ellinger is leading the way, and I would hope that we could partner together and really hope to get some things moving this year to really start to I think Dr. Rogers talked about the prevention part of this. If we can catch colorectal cancer early, we have great success. Dr. Ellinger talked about if we could just get young people and people to either stop or kids to never start, then we know that the rates are good, they're through the roof. So we're hoping to really get these guys to help push this issue so that we can see some success. And from there, I think it has a snowball effect like everything else. And hopefully next year, 5 years from now, we won't have this conversation. And that's what I'm hopeful.
Sure. Well, Dr. Rogers, I want to ask you as well about one of the themes that comes up in the documentary. And that is, frankly, among underserved communities, there's often a distrust of the healthcare system itself. And I mean, if that is a cultural component here, I mean, there's one thing about telling people to get to screen, but if the context is, well, I don't trust the healthcare system to start with, how do you deal with that?
So again, David, it's a very complex issue. So with me, even in my work, I initially started out doing some work with a chief colorectal surgeon named Artie Morris in the University of Michigan, and she was trying to see why African Americans would get colorectal cancer surgery where they wouldn't get chemo. And so what she noticed is that you had a African American male and a white male, both of low social and economic status. The white male would get chemo because he sees that he needs to stay alive and support his family that way, whereas the African American male would not get it because he sees that he needs to stay at home and go to work to support his family that way. So even on top of that, if you look at the same scenario but had an African American male who had better social and economic status, he would go and get 3, 4, maybe 5 other opinions before he would decide to get it. And so she was really trying to see if it was something in terms of the provider saying that we got it all, that was something that was triggering in their mind to make them feel that they didn't need to get it. But again, to come back to your question, I think by having these conversations more and more and making it seem like more of the standard that this is what happens, that more people will be more willing to think to support it. You understand what I'm saying?
Yeah, I think so. I'm wondering, are there opportunities for patients who are facing these questions and these balancing acts with their personal lives to talk to people with similar life experiences who have been through it? I'm thinking of like the support group model. I would think if you were challenged by taking on treatment, it would help to talk to someone who's been through it and say, here's the reality of what I went through and why I'm glad I did it. Is there any infrastructure that allows people to talk on that level?
Yeah, so I know those are definitely in place for breast cancer, but I'm not aware of any of those for colorectal cancer.
Maybe let's talk to Commissioner Ellinger about that. Is that an opportunity to have more, I don't know, community conversations or even chat backs, so to speak, about people who have experienced it?
I think Dr. Rogers brought up a really important point. The fact that some people don't go to get the care they have because they can't afford to leave their job. And we just did a report on paid sick leave and how having access to paid sick leave makes people healthier. They get screened earlier, they get screened more often, and a whole variety of health indicators happen. And the people who don't have paid sick leave are low income, lower educated, and people of color and American Indians. So this is one of those policy issues that people don't really recognize, that actually having paid sick leave for everybody would actually reduce disparities and would actually probably reduce colon cancer disparities, because people could afford to take off from work to get screened or get the treatment they have because they wouldn't have to worry about job security.
Sure. Well, that dovetails nicely with a big legislative discussion this year, Senator Hayden. Paid sick leave is being talked about in St. Paul. What's sort of the latest on that conversation?
Yeah, I think Dr. Ellinger hit the nail on the head. Paid sick leave, though being opposed by the business community, is really good for business. So not only this issue of being able to take time off if you're, really ill, but just the common cold or the flu. Who wants to have somebody come to work if they're not feeling good and they're spreading kind of their germs, if you will? It also gives, as Dr. Rogers says, it gives people some stability to know that they can take some time off to get themselves well and to treat the disease. Dr. Ellinger last year, I think in the Health Equity Report, if not a different white paper, talked about the minimum wage and how important that was as a public health issue for people to raise their wage, and that is a factor that really helps public health. I think that this issue of having equitable pay, having time off, is extremely important, and it doesn't kind of fit the normal medical model, but I think Dr. Ellinger and his folks have really laid that out, that might be some of the most significant things that we could do to help people be healthy and to get screened. So I think that that's important, and I think that this is something that our business community, who often opposes these things, really has to take a look at as we start to move forward. The one thing, David, I wanted to add a little bit about what can we do. I think that Dr. Rogers, Dr. Ellinger, of course, is fantastic, but Dr. Rogers or myself or other people in the community who looks like the community, who the community trusts, who kind of speaks some of the same language, I think that that is significant in the work that we do. So as we continue to move forward to make sure that we're hiring people that look like the folks that we're serving, that we're educating them, that we are really kind of reaching out to community partners that really have the trust of the community. I think it really goes, David, to the conversation you had about this trust that you talked about that will be in the documentary. Part of the lack of trust is that often people don't know who their provider is. They don't know who's treating them. They don't trust them because they just don't have a relationship with them. And one of the things that really helps with that is having people who look like the person that they're treating, that person is either in a provider or a liaison or some sort of community way. I think that really is helpful. I know personally, when I chose a provider 6-7 years ago, one of the significant things was it was an African-born doctor who had done a lot of research on African American men. I chose that provider because I trusted that he really understood me, and that ended up to be at an FQHC, at a federally qualified healthcare clinic that obviously I don't have to go to, but I still go to today because I really trusted that provider. And I like to tell that story because I think it's significant.
Absolutely. Well, let me ask you, Dr. Rogers, to Senator Hayden's point, if someone hears the message today and decides to go get screened, what are the odds in Minnesota that they will encounter someone who looks like them and talks like them, who can provide the same experience Senator Hayden had and increase that trust? I mean, what are the odds that encounter can even happen in Minnesota?
Yeah, so I'm not absolutely aware that the commissioner may be able to add to that, but I did want to point that another recommendation, I think, is actually giving a community opportunity to even speak. I know the MDH is really good about when they have certain big things that are going to come, they get a lot of feedback from the community. And so in the work that I do, which is really community-based work, community-based interventions, I'm really big on making sure that anything that I do in the community, I get their feedback first on things, on the findings that I find, or even on things that I want to do in the future. So that's definitely a point that I want to bring up. But he may be able to address your question that I can't at this time.
Well, before we run out of time, Dr. Rogers, I did want to ask you probably the most difficult question I was going to ask today. And as just an average Joe, I'm even uncomfortable asking it, but I think it's valuable for the conversation we're having. Someone gets the message and they want to go in and get a screening. What exactly are they in for? And I know we're on the internet here and everything. We don't have to get all the details, but is it an in-and-out procedure? I mean, it's scary stuff. What will a person experience if they decide to get screened?
Right. So my mom recently finally got screened because of the Affordable Care Act. And so when she got hers, the most uncomfortable thing was that she had to fast. She couldn't eat for a day or so, and so she basically had to drink some mixture to help her cleanse her system. But besides that, she went in. They did the procedure. They found a few polyps. Thankfully, they weren't cancerous, and that was it. And now she's good to go. So it's really an easy thing to do. It's just I think that a lot of us have this misconception in our mind that it's painful or that some other issue is going to occur, that I have to cut off something, when it's really just quite easy. It's simply easy.
Are you able to walk out the door, so to speak? I mean, it is an in and out. Besides the fasting, it's an in and out procedure. You drive yourself home and all that.
I think that sometimes you have to have a driver. Don't quote me, but I think so. But again, it's still a very simple procedure.
Sure, absolutely. Well, thank you for answering that. And Commissioner, I just wanted to bring you back in from a macro perspective. Going forward the next few years, what are you really going to be looking for benchmarks about whether Senator Hayden's, Senator Champion's legislation is having an impact? How do you sort of measure the tail end of these legislative initiatives we're taking on?
Well, David, I think there are three things that have come up, and Senator Hayden had really identified at least two of them. For us to move forward. One is we have to change the conversation about what creates health. It's not just about medical care, and it's not just about personal behavior. It's really about the socioeconomic conditions in which people live. And so that is where the policies come in place. Secondly, we need to have communities who are empowered to help create their own healthy futures. And what he's doing with the grants to community organizations, getting them empowered, because that's where we can really make a big difference. And then there's a health in all policies approach that we really need to look at. What housing has to do with, what socioeconomic conditions have to do with, what paid leave, income stability, all of these things. And we will be able to see those from the policy decisions, and then we'll start seeing some change in behavior, and we'll start seeing those rates. But those rates probably won't come down for a couple of years.
Great. I think just one question for each of our panelists, and then we'll wrap this thing up. But Senator Hayden, there's a lot of issues moving through St. Paul, a lot of competing interests. What's the reception been for your sort of legislative agenda on this? Has the reception been good?
You know, it has really been good in the Senate. Senator Laurie and Senator Sharon, both the chairs, have agreed to I think both of them, our appropriations, have agreed to hear the bills. Senator Sharon has done great work and has spent a lot of the committee's time going over the health equity report and is very, very interested in it. I know that I've worked with MDH and Dr. Ellinger's group to kind of put these proposals together. I wouldn't begin to kind of put words in his mouth, but I would hope that he'd be supportive and put in a good word for us with the governor.
I think politics just happened right here on the chat back.
And then, I haven't had as much a conversation with Representative Mack or Dean, who I served with as well, but I know that they have been hearing bills that concern this issue. Their spending target is a little different than ours, and I won't overly politicize it, but some of the recommendations they have in their committee I disagree with, because it targets this particular group of folks. But once again, I won't turn this into a political conversation. So I am hopeful, though, that we can get at least some of these policy initiatives and some of these resources in the overall budget deal that we're going to deliberate over the next 6 weeks.
Great, thank you. And Dr. Rogers, sort of the open-ended hope question. I mean, you strike me as an optimist, someone who commits a lot of time to this. First of all, is that true? Are you optimistic about the way things are going? And if so, what leads you to feel that way?
Yes, again, like I mentioned earlier, Minnesota is one of those places where they can really make change. And so even though, like for instance, the Minnesota Community Measures just released a report talking about a number of things, including colorectal cancer screening, and they made the point that, in the Somali community, which is the largest in the United States in terms of the state of Minnesota, they have a screening rate of 17%. I think it's great that we even do that, find out where the problems are so we can actually take steps to make changes. And so, again, I'm very optimistic because I think that there is a lot of people that are on the ground that are maybe behind the scenes like myself or commissioner or senator who are really about not just talking and really doing some walking in terms of making things happen.
Absolutely. Thank you for being here today, by the way, Dr. Rogers. And then, Commissioner, just sort of the broad strokes materials question or educational materials. Someone's at home, they're just watching this on their computer, they want to start Googling or looking at some reliable sources. Can you steer them to any starting points to just get more sort of factual, reliable information on these issues?
Well, you certainly can start with what we have on our Minnesota Department of Health website. We have a lot of information about a lot of diseases, a lot of connections, particularly for the screening programs that Dr. Rogers talked about. We have programs that are available for folks to help them get screened. So that would be a simple and good place to start, the Minnesota Department of Health website.
Great. Thanks so much, Commissioner. Thanks to all of you for being here today. We really appreciate your time. And just a quick reminder for those watching that we do have the documentary tonight at 10 p.m. on TPT2, Living Beyond Cancer, a Celebration. And we do have 3 other chatbacks that are available online, including a very fascinating one on the advancements in science and treatment, which is riveting stuff. So thanks, everyone. We'll see you soon. Best of luck with your work, and thanks for making time.
Appreciate it. No problem. Thank you.
Thank you, David.
All right. Bye-bye, everyone. Talk soon.